Hello, we're glad you're able to join us today for ECG's 2024 Advanced Practice Provider Market Outlook webcast. I'm Aurora Young, a partner at ECG in our Provider Financial Services division, and I'm pleased to be your moderator today's program. In this webinar, ECG's experts will share some key trends related to advanced practice provider compensation plan design, utilization, and APPs and provider care models, as well as offer insights into key performance trends related to APP compensation, production, and practice profiles. We will present our outlook on APP compensation models, and we will offer best practice recommendations on how organizations can navigate the regulatory factors such as split shared billing and the 2024 MPFS. We will end our program with a case study to help illustrate how one organization addressed these trends in their APP compensation plan design. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 60 minutes in length, which will include about 55 minutes of presentation. Everyone should have received a copy of the presentation, but if you were late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, and if you have questions, you can type them into the question pane on your screen at any time. Unfortunately, we will not be able to address questions in the presentation today, but we will be creating an FAQ compiling the questions that will be sent out after the webinar via email to all participants. We will be launching a few audience polling questions today and hope that you will participate in this interactive measurement tool. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is very important to us. And for each completed survey, ECG will make a donation of $5 to Doctors Without Borders. So now let's meet today's speakers. We have Maria Hayduk, who's an associate principal with ECG. She has an extensive experience in medical group and provider market surveys and benchmark development, provider compensation planning, medical practice and organizational performance improvement, and academic medicine. At ECG, Maria leads our provider analytics practice, including production of the firm's national physician faculty, APP, physician, and medical group performance studies. For over 20 years, Maria has overseen the conduction and expansion of ECG's national adult and pediatric subspecialty physician, faculty, and APP compensation and production surveys, and she has played an integral role in launching and expanding the firm's medical group performance survey for large integrated healthcare organizations. Welcome, Maria.
Thank you, Aurora. Great to be here.
So we're also joined by Sean Capello, also an associate principal at ACG, and with over 15 years of experience developing and implementing data-driven methods for solving strategic, financial, and operational challenges, with specific focus on provider affiliation and compensation models. Sean's expertise is in helping his healthcare clients assess and align their provider arrangements with their organization goals, balancing the core principles of remaining market competitive, aligning performance, ensuring financial sustainability, and regulatory compliance. Sean has extensive experience working across all types and sizes of healthcare organizations with a client base that is nationwide. Welcome, Sean.
Thank you, Aurora. Looking forward to the discussion.
Okay, and then we also have today Tanner Heggie. Tanner is a manager here at ECG and is a member of ECG's valuation and compensation design practice. One of Tanner's greatest strengths is ability to utilize data analysis to tell stories and implement change. While Tanner excels at generating data-driven solutions, what clients value most are his enthusiasm, team player attitude, and passion for creating a better healthcare ecosystem, which he brings to bear on every engagement. Welcome, Tanner.
Thanks, Aurora. Very excited for today's discussion.
Okay, so we will just quickly review the agenda for today's discussion. Our first conversation will be just a quick introduction to the topic and imperatives for change in advanced practice provider compensation planning. We'll move into kind of the meat of the conversation related to our surveys and benchmark trends led by Maria Hayduk. And then we'll end the conversation, as I mentioned, with a conversation around how one organization approached its APP compensation planning and design for 2024. I'll now turn the conversation, I meant to do a quick introduction of the firm. as well. So just quickly, ECG is a national consulting firm. As you can see, we're nationwide with 9 offices across the country and over 50 years in operation. We have over 240 consultants providing strategic services, financial advisory services, operational and technology solutions to our clients. On the next slide, you can see a bit more about our core expertise as it relates to advanced practice provider compensation design. This is a growing and exciting area for our consulting practice. We have a dedicated group of consultants, most of those on the phone with you today, who work on advanced practice provider compensation design, helping our clients to solve complex issues related to not just the design, but care models and utilization and how they think about advanced practice providers across those subsets. We have a dedicated survey on advanced practice providers, looking at compensation, production, and pay practice trends, which is a growing subset for not just the benchmarking, but supporting our advanced practice provider work. Again, we work throughout the country and have highlighted here, just so you can see some of the areas we're doing more significant work on advanced practice providers, but with growing trend and prevalence in these engagements throughout the country. So on the next slide, I'll turn this one over to Tanner Heggie.
Awesome. Thanks, Aurora. I think a key word that Aurora was mentioning in the background for our work within APP compensation planning is growth. It's a really hot area for our division, as there's a lot of imperative for change out there. A lot of organizations are facing industry challenges or drivers for change, and oftentimes they're looking to their APP workforce as a key answer for helping address those issues. This slide here is kind of an overview of the intersection between the two industry drivers and APP trends, and then in the following slides we'll dive into a couple of them a little bit deeper. But some of the key drivers we're seeing is physician shortages. So currently there is a deficit of physicians for the demand of care needed in the country, and that deficit's only projected to grow further and further apart. There's also a shifting focus to value-based care initiatives, both in achieving an organization's mission and providing the best care to their patients, but also in the reimbursement landscape as well. And then overall, there's industry reform to increase access to care, as well as reducing the cost as margins are becoming more and more razor thin. Fortunately, the APPs really tends to be a great solution or intersection for addressing many of these challenges. There's a growing supply of nurse practitioners and physician assistants, but not only is the supply growing of folks in the workforce, but also their roles within care teams is rapidly expanding, both in areas of service as well as scope of practice. And then kind of tying it back to compensation, many organizations are looking to APP comp plans as really a helpful support in enabling providers to practice at their top of license and really be aligned with organizational goals. We don't have to go through all the benefits listed in the middle here, but having APPs in your care model, as many of us know, can be a great advantage for organizations, such as increasing patient access, providing lower cost of care settings, and improving patient experience altogether. So on slide 8, we'll dive into one of those industry drivers a little bit further, and that's the changing provider workforce. As I previously mentioned, there is a physician shortage, and it's projected to be between 50,000 physicians and 120,000 physicians shortage by 2032. And a key component of that is the projected job growth of physicians and surgeons, according to the Bureau of Labor Statistics, is only 3%. Fortunately, the tale for APPs is actually quite the opposite. I know last year BLS reported that nurse practitioners is projected to be the fastest growing profession in the United States, with a projected job growth of almost 40% over the next 10 years. And physician assistants really aren't that far behind, seeing 27%, which is still far higher than the average. And then just to drive this point further, one more time, is AMN Healthcare, formerly known as Merritt Hawkins, is a very popular, nationally recognized resource for healthcare provider recruitment. And every year they publish what is the most recruited and sought after medical healthcare provider. And over the 30 years, it's always been a physician specialty until the last 3 years, where nurse practitioners have actually topped that list. So just further driving home the high demand for APPs and the organizational priority of everyone to get them on board. So on slide 9, we'll talk a little bit more about value-based care. I know this is a big buzzword, and every organization may look at value-based care a little bit differently. But here at ECG, we tend to break it out into 5 different domains: service excellence, citizenship, access, quality and safety, financial stewardship. Your organizations may reward it or look at domains slightly different, but I think we can all agree that APPs can play a pretty significant role in every single bucket here. I mean, for example, access, we talked about it on the last slide. With a physician shortage and a rising APP workforce, bringing APPs in to open up the doors to patients and provide that greater access can really be a huge lift for organizations and getting that door open for patient care. Financial stewardship, APP compensation tends to be around 40% of their physician partners. So it can really be a great alternative source of care, especially in those lower risk settings for providers and patient care. As we flip to slide 10, we can talk about one of the key complexities, especially for APPs, and that's scope of practice. For APPs, the way that they're practicing within their care team can significantly vary across specialties, within specialties, and sometimes even within the same clinic. The way that we look at APP roles is really across a spectrum of independence. On the left-hand side, the physicians tend to be much more of a physician support role. We call this a practice extender. It tends to base off of the history of APPs, which usually stems from more of a nurse-based background. And in this setting, APPs are often performing activities such as managing the inbox, taking health histories, physicals. And in our experience, most organizations are actually trying to move away as much as they can from practice extenders and really push their APPs to practice more independently or top of license. So when we switch over to a collaborative provider, it tends to be a mix of both practice extending and more of an autonomous, independent setting. So one example could be cardiovascular surgery, where the APP is in the OR providing surgical first assist, but they may also be doing all the follow-up care independently, which allows the physician to continue in the OR and practicing at their top of license, and the APP providing that follow-up care. And on the far right-hand side, we list independent provider. When I think of this, my first thought goes to primary care, where potentially an APP is the go-to source of primary care. They have their own patient panel and they're directing the care for their patients. But this could also be done in multiple other settings, such as dermatology, nephrology, and many more. The one caveat, as organizations try to push more towards independent practice, is the state legislature, laws, and regulation can vary significantly for what can APPs practice at. And that could include things such as evaluating, diagnosing, ordering tests, and prescribing medication. So that's something organizations definitely have to take a look at and ensure that they're abiding by those regulations. Then on slide 11, just the last imperative for change that we'll speak to today, and that is many organizations, as APPs are becoming more independent in practice, similar to their physician partners, their compensation plan is also becoming more and more aligned with a physician type plan. There are many benefits to this, such as potentially having more team-based goals and behaviors, so clinics and care teams can operate together at the top of their license and support the total clinic or operation as a whole in a team-based nature. There's also the ability to set up compensation plans where both the physician and the APP are aligned in their behaviors and relationship between complexity of patients served, and really focusing on that top of license practice. For equity, as APPs practice more like physicians and they're becoming more responsible for components of care such as access and quality, we're seeing more and more organizations align their compensation plan to reward those responsibilities and metrics. And then lastly, instead of having two disparate plans between APPs and physicians, if you have similar mechanics and structures, it can be easier to administer these types of plans if they have many similarities and functions. And then you may be asking, how can we have APP comp plans look more like physicians? I think the one that comes first to mind to me is, what are the performance incentives in place? You can have very complementary goals where physicians and APPs are working towards the same quality outcome metrics or patient access metrics. Some organizations even have team-based funding. So instead of individual access, maybe it's the clinic at large. I think there are some additional complexities there, but it's definitely an opportunity as compensation plans become more aligned. And while not related to APP comp plans alone, APP supervision incentives for the physician is becoming more and more popular. In order to support APPs at their top of license, we still have to recognize that there is some physician involvement to ensure that you're compliant and providing the best care necessary. And then lastly, market-based compensation. Most physician comp plans out there do reference nationally recognized survey sources such as ECGs or MGMA or AMGA. And those surveys also publish APP subspecialty benchmarks that more and more organizations are starting to reference in order to be competitive and aligned with their physician partners. So with that, we'll actually turn back to Aurora to do our first polling question, which will talk about which one of these imperatives resonate with your organization the most.
Great. Well, thank you, Tanner. So our first polling question should be appearing on your screen and reads, please select the top 3 imperatives for change in advanced practice provider compensation that resonate with you and your organization the most. Please select any of the top 3 on this list. Changing workforce composition, more APPs, less physicians. Supporting value-based initiatives, access, quality, etc. Promoting APP top of license. Recruiting and retaining advanced practice providers. Or aligning advanced practice provider and physician compensation plans. So we'll give you just a couple more seconds to continue to answer the polling questions, and then we'll close the poll. Really looking forward to hearing what other organizations are dealing with or thinking about as imperatives for change in your advanced practice provider plans. Okay, so here are our results. As you can see on the screen, the number 1 imperative for change is the recruitment and retention of advanced practice providers at 72%. It was almost tied with promoting advanced practice provider top of license practice and aligning physician and advanced practice provider comp plans, but still pretty, relative, about 50% of organizations did indicate that supporting those value-based initiatives are important to their organization. And then, 44% indicated that changing workforce composition, moving towards higher kind of employment and larger APP cohorts and less MDs. So with that, I don't know, Tanner, if you had any thoughts. Otherwise, we can jump back into the presentation.
Yeah, I mean, my initial reaction is just the fact that all of these answers are pretty uniformly selected. I mean, the lowest one, changing workforce composition, still almost half of people selected that. And with all of our engagements in APP comp redesign, it honestly doesn't surprise me much. I bet if there was an all of the above option, people would have selected that because there's a lot of imperative for change here and lots of exciting opportunities within APP comp for sure.
I would absolutely agree. Working with clients on advanced practice provider compensation, I think it would be hard to pick any one of these and not address all. Okay, well, let's jump back into the presentation and we'll turn it over to Maria.
Thank you, Aurora and Tanner, for that. That's super interesting. I'm happy to be here today and to see so many of our survey members actually who have been able to join us. Many of you were on our fall webinar, member webinar, and we covered high-level APP findings and indicated we would dive deeper at a future webinar. And so, here we are. The APP trends I will present on the following slides were derived from that 2023 APP compensation survey, which we released in mid-2023. So keep in mind that the data from the 2023 survey represents fiscal year 2022 performance. We're currently in the middle of collecting provider data for our 2024 survey, and those results based on 2023 activity will be released here in the next few months. For more information about participating in that survey or anything else regarding that, there's information at the back of this presentation. So with that as background, I want to begin to highlight some of the key trends we were able to discern from the data from the 2023 survey. Most of the trends are focused on nurse practitioners and physician assistants, but I've included information on CRNAs where we thought it was important to do so. APP compensation rose more than 8% over 2022, with surgical APPs realizing the greatest gain in compensation of nearly 10%. CRNA compensation has been steadily increasing, and our survey shows an increase of 4% for median compensation. Since compensation did dip during COVID, we wanted to show you a comparison of where the medians are now compared to the time period before COVID happened or before COVID began. So APP compensation is almost 13% higher than before COVID, while CRNA compensation is medians are 18% higher than before COVID. And I don't think that will surprise many of you here today with us. The bar chart on the right demonstrates the median compensation across a select number of APP specialties, including several of our surgical subspecialties and emergency medicine. All of these subspecialties, APP subspecialties, have median compensation over $140,000, with the cardiovascular APPs surpassing $180,000 in the median. Then on the bottom right, we show how median RVUs have also been on the rise over the last few years. And I'll tease apart these high-level findings on the following slides, but I wanted to point out one thing is that RVUs in our findings are calculated from CPT data submitted by our survey members. So we do not include self-reported RVUs in our benchmarks at all. And as a side note, we've done a substantial amount of review and study of the impact of the 2024 Medicare physician fee schedule on RVU medians, on benchmarks, on physician benchmarks, as well as APPs, and the new G code and split share billing. So if you have questions about that or want to follow up with us later, we're happy to share that work we've done. On slide 14, as Tanner mentioned, there are different laws and regulations that apply across the states where the practices represented in our data set where the APPs are practicing. And so we wanted to see how our survey medians vary depending on an APP's practice location and the different laws and regulations that define or restrict how APPs are utilized. And so for this reason, we looked at our survey medians. On the left table, you see our survey work RVU medians for nurse practitioners practicing in one of three environments, including a restricted state, a reduced practice state, or a full practice state where they're able to practice at the top of their license. And our data suggests, as you can see, that the medians are higher in both the reduced and full practice state, and that the restricted state medians are somewhat lower than the other locations where nurse practitioners are able to practice closer to the top of their license. Similarly, for PAs, their laws are worded a bit different, but are essentially the same as NPs and levels in how the PAs are able to practice at the top of their license under either optimal and or advanced state. For For non-surgical PAs, our medians are mixed, and there's really no clear conclusion on how the restrictions impact the medians. But in surgical PAs have similarly mixed results as well. However, the reduced practice dates for surgical PAs, those medians are lower. So all this is to say that the varied practice environments will influence production benchmarks, and to be cautious when you're using national production benchmarks for nurse practitioners in particular, and the surgical PAs, if your state is, your APPs are working in a restricted environment. So on slide 14, next, or on the, yes, that's right. Next, we compare compensation and production of APPs to physicians practicing in similar specialties. Our findings have changed a bit since we began running these types of analyses historically, and these trends likely the result of the movement of organizations to the innovative compensation and care models for APPs that Tanner was referring to. So median compensation for hospital-based and surgical specialty APPs are proportional to the median work RVU production of physicians. But on the other hand, primary care and medicine APP compensation medians are below where our work RVU production would seem to indicate if it was proportional to the production figures of what the physicians are generating. And the charts on the right show the APP median compensation and work RVU by specialty category. But as I show these numbers, it's important to note a couple of key points, including that APPs, as you know, are reimbursed by Medicare at 85% of what they pay for physicians. So while the RVUs may be proportional or less or more proportional than the earnings, the revenue is not necessarily following. Similarly, with commercial payers, they generally reimburse at 85% of the allowable rate or 100% of charges for APPs. And as a side note, it's just in reviewing your APP commercial contracts and the reimbursement, sometimes payers will not pay 85% of the allowable amount. They pay 85% of the Medicare amount. And we've seen this with some of our clients. And so they're getting under reimbursed by their commercial payers. So it's super important to take a look and to make sure that you are at a minimum setting your charges higher than the payer allowable, and then confirming that they are reimbursing you that 85% of allowable, not 85% of Medicare for your commercial business. And then secondly, the work that APPs are doing is generally on the lower acuity side, with the average work RVU per procedure for APPs being 0.5 work RVUs, while physicians are generating 0.73 work RVUs per procedure. And this makes sense as organizations are trying to use, are attempting to use each provider type at the top of their license. And we're able to discern those average acuity numbers because of the CPT data that we collect from all of our members. On the slide 16, getting into our findings of APP performance by compensation plan type, not surprisingly, we see earnings and production go up as compensation plans begin to include a higher variable amount component. We did look into whether this trend changes across different state environments due to the regulations, and we see similar distribution of compensation and production by comp plan type when we excluded APPs who practice in restricted or reduced practice states. So our findings indicate that as more organizations adopt variable plans, we see both compensation and work RVUs increase. Maybe that is obvious, but it is an interesting finding that as we migrate to these variable plans, we are seeing higher earnings and higher production. We also wanted to point out a few limitations of the fixed salary arrangements, including the inability to tie pay to performance in a meaningful way. Sometimes there is a misalignment of compensation with production and value-based initiatives and or organizations' strategic goals. And finally, there's a potential to create perceived inequity among APPs who are, really practicing differently, have different roles, different responsibilities, and likely different care models. On the next slide, we dive deeper into APP variable compensation plans, trends, and components. And we find that base compensation as a percentage of total compensation has decreased over the last 3 years as the variable component grows. We see that on average, 91.3% is where we're seeing base compensation being set across all NPs and PAs, 91% of total compensation. So concurrent, but of course that's going to vary depending on roles and responsibilities, the practice models, by specialty and by organization. But concurrent with this trend, we find that variable compensation measured by quality and our patient satisfaction performance, as well as production compensation, are also increasing. Overall, APP value-based compensation has hovered around 6% over the last 2 years. And that, it seems like it's hovering, but it wasn't too long ago that we were seeing the quality compensation for APPs around 2%. So this is a significant increase. And then variable compensation is making up in total around 8 to 9% of APP total comp. And as I mentioned, this is going to vary depending on all of the things I mentioned, roles and responsibilities, practice models, specialties, etc. Finally, on my last slide, slide 17, slide 18, we're reviewing our benefits and recruiting market data as well, and it indicates that organization cost of benefits increased by nearly $3,000 per FTE over last year. So not only is compensation going up, we're seeing benefits going up. We also find that CME allotments for APPs have increased over the last 3 years, averaging around $2,800 per provider, with 100% of the organization responding to this question, indicating that they provide this benefit. And then concurrent with the compensation increasing, signing bonuses are also increasing as competition for APP accelerates. We have great data on CRNA starting salaries and signing bonuses, and signing bonuses have increased by nearly 50% since 2021 to over $30,000 for CRNAs. And we have seen evidence of that signing bonus even surpassing $40,000 per CRNA. So I know that's a lot of data to digest in a short period of time, but I appreciate the opportunity to share our findings, some of our findings. And so with that, I'll pass the presentation back to Aurora and Sean to present our case studies.
Thank you, Maria. So as Tanner discussed, APPs have increasingly become a larger part of health systems provider enterprise strategy, to improve things like patient-centered care and access. And comp models are really an important vehicle to aligning providers with those operational plans and care models and execute on those broader organizational strategies. As such, well thought out design is critical to driving success. APP comp models should not only reward the desired behaviors, but they should also reflect an APP's role within a care model, which we will introduce here on slide 20. APPs have a variety of roles within care teams, and we covered these earlier, but we'll introduce them again. And so most commonly we see APPs within an extender role, collaborative, or independent in their own right. And given the scope of practice associated with these roles, different compensation design is appropriate to consider. Namely, the mix of incentives and risk go up as APPs are in a position to bill and manage their own patient panel. The stacked blocks here represent a target mix of compensation across high-level components of pay. The target amounts or typical ranges will certainly differ due to the integration of these variable pay components and the risk-reward profiles that are inherent in them. Generally, the components should reflect the aspects of practice performance the APP is able to influence. With extenders, we're seeing that they're primarily focused on creating overall practice efficiency and improving patient satisfaction. Therefore, a salary-based model tends to be, still more appropriate with maybe a bonus tied to something like patient satisfaction. Collaborative providers will have a mix in their scope, but generally some ability to bill. As such, we begin to see components that recognize high productivity and allow compensation to reflect that performance. And given the team-based care environment, though, we do not want compensation models to get in the way of making the right decision for the patients, so we don't tend to see downside risk incorporated here quite yet. The base portion may be very similar in amount to an extender base, but there's upside potential crafted into these models to be available to APPs that are performing above market production in their role. As we move further to the right, the independent providers tend to practice more similar to a physician practice, seeing lower acuity patients typically. So you see a much more similar model to physicians here. So in this case, we have some downside risk incorporated. So the base component would be set lower than they might be for other types of scopes of practice. But the upside potential through things like productivity or other value-based metrics would generally exceed that of the collaborative model, since the independent provider is taking on more risk in their compensation. So when we begin working with clients on APP compensation, they do tend to have historically used models resembling that on the left, but for all APPs across their enterprise. It can be daunting for several reasons to make the cultural shift toward the right, and very challenging. So before we dive into a case study, we would like to hear from you on this topic first.
Great. So on the next slide, we'll start our next polling question. It should be appearing on your screen. So the question is, what do you anticipate, or what did you face if you've been through this APP compensation redesign as being the biggest challenge in adopting performance-based APP compensation plan components? So please select any of the following. The first one being, do not want to rock the boat in a competitive recruitment market for APPs. Maybe your competitors aren't doing it. You worry about the cultural adoption kind of within your APP cohort of moving towards performance-based compensation. The competition with physicians for work RVU credit being a factor. The next question is, or the next opportunity, point being inability to recognize non-work RVing activities performed by the APP. So again, having challenges attributing quality, patient satisfaction, or other metrics of kind of non-work RVU performance. Inconsistencies in how APPs are practicing across care teams, across specialty, or even within a given specialty. And then the last one, APP compensation is too low to take on the additional risk. And I think this is really meant to say, organizations are challenged kind of with this being typically upside risk and balancing kind of that financial sustainability, maintaining a competitive salary, and shifting to a risk-based or performance-based component, and potentially the cost associated with that. So with that, here are our results. This one, I think we see a lot more variability in the results. The top two you can see here is the concerns around competition with physicians for the work review credit, and then the inconsistencies in how APPs are practicing across those care teams. Almost 50% of organizations said the inability to recognize non-work review incentives are probably hindering the adoption of those more, quality, patient satisfaction, more value-based metrics of performance within the plan. The two least recognized or kind of chosen options were the do not want to rock the boat in that, kind of competitive market, and then APP compensation being too low. So it really is organizations, faced with the competition for the work review credit, that, the inconsistencies in those care models and the utilization of APPs really driving some of the challenges in looking at performance-based. And I don't think it's any surprise to anyone, the inability or challenges with recognizing those value-based activities being a challenge for, APP compensation models. I think we all also recognize those are some of the same barriers in physician compensation models when we talk about quality and value-based incentives and attributing and having the systems in place to measure those. So Sean, any additional thoughts on these results before we jump back?
Yeah, these are really interesting, and they speak to a few of the elements that we'll discuss within the case study here shortly. Speaking to the top two real quick, so inconsistencies in how APPs practice across care teams, this is certainly a factor, and we'll talk about how we brought considerations of this into a process for compensation design at this organization, and really having to understand the nuances across all the APP groups within an organization. It's really critical. Competition with physicians for work review credits. Commonly physicians may be under a different employment vehicle, and this is certainly an operational consideration that needs to be tackled in partnership with your physician leadership, and so we'll talk a little bit about that as well. So we wanted to discuss an APP compensation redesign engagement we recently completed, and not so much to focus on the outcomes of the engagement, but more to highlight the process for overcoming some of these challenges to achieve this cultural shift. The client we're going to discuss is a community hospital offering a coordinated spectrum of services across primary, specialty, and surgical care to a relatively large geographic region with many rural areas. APPs are critical to them in delivering on their commitment to providing access to their community, particularly within the rural parts of it. They already had a sizable APP workforce, but needed to grow and certainly retain as they were experiencing competition within their own market. They also needed their APPs working at top of licensure to deliver on the patient care. Like others, they were starting from a fixed salary with some tiering tied to specialty and years of experience, but there was a lot of inconsistency in application of even that, and really no mechanism to reward high performers. To recruit and retain top talent and align APPs with their desired operational models, this client needed a market competitive, performance-based, and clear APP compensation model. But as you highlighted in your responses, they also experience cultural barriers to achieving that. So let's now take a look at those. Being an integrated care system, the spectrum of APP practice was wide and nuanced, sometimes even within the same specialty, such as orthopedics was really one we had to dive into a lot. Further, these nuances are not necessarily obvious to non-clinicians. So this process was led by a steering committee, and that included representatives from a set of several APP leaders. They provided immense context and considerations throughout the process that heavily informed our ultimate design and model selections by specialty. The next two listed here are potentially related, one may be driving the other. As is common, I mentioned earlier, the physicians were in an independent medical group and the APPs were employed by the hospital. Additionally, certain bylaws limited the APP practice. And in this state, it was actually a relatively progressive in terms of APP scope of practice. So APPs need to be set up to be successful under these models. And part of that is eliminating unnecessary barriers. A concurrent strategic initiative at this organization, co-led by forward-thinking physician leaders, tackled these issues alongside our work, which was critical to the success of the compensation models. As Tanner discussed earlier, they evaluated new ways to think about APP supervision and those interactions between physicians and APPs, so that operations really helped them treat the patient populations they had and directing patients to the right care, the right provider at right time. And I think that they're finding now that the overall work RVU pool and amount of patients they have been able to see are increasing, right? You have a much stronger team focused mindset, much more efficient practice. They're seeing more patients and not seeing work RVUs diminished on either side. And that's a collaborative process across provider leadership. And these types of models really, especially if they're aligned in what's being incentivized across groups, can really get the full team all rowing in the same direction and rising all tides. Readiness to measure and report certain metrics was ultimately a limiting factor for the range of metrics within the compensation model that could recognize APP contributions to care teams. And this was really related to certain quality metrics that may be aligned with some of the reimbursement models that the organization had. or certain patient experience measures that they were looking to achieve. So we were unfortunately not able to move all specialties that we would have liked to a performance-based pay type model. And some of the specialties were very eager to do so. So it was a unfortunate aspect of this engagement that we weren't able to achieve in a first phase of their path towards more performance-based pay. However, the compensation models they arrived at served as a much stronger chassis to add on metrics over time as they developed that IT infrastructure. And a really important commitment by leadership of the hospital was that they would be evaluating each year, readiness and pursue paths to incorporate more performance-based pay for APPs so that they can earn compensation that reflects their performance and against some critical measure. Because again, a lot of the APPs were really eager to earn relative to their performance, and that's a good thing. Trust is absolutely key, and that could be more challenging depending on how past compensation redesign initiatives may have gone, even if performed under a since departed administration. Transparency and communication in a redesign process, without sharing sensitive information, need to be priorities 1A and 1B throughout the entire redesign process. I will also revisit including APPs on the committee, as I mentioned earlier. Giving them the charge to liaison with the rest of the APP group really puts them in a position to help build that trust and improve transparency in a way that the APPs are really going to understand and resonate with. They also have a sense of representation within the entire process. In this engagement in particular, we had an incredibly engaged, thoughtful, and committed set of a group of APPs on the committee, and that may have been the most important attribute to success of the entire project. Finally, APP benchmarks are not always as straightforward as those for physicians. Are they good measures for how we deploy our APPs in a given specialty? How or should we even use them in comp? And these are really important questions to think about, as Maria introduced previously. So next, we'll look at some of the approaches we use to guide this discussion. So ultimately, we helped this client with a few foundational improvements to their APP comp design. First, a clear and market-based approach to setting base or guaranteed comp that considered specialty and years of experience. Where appropriate, there were mechanisms to recognize participation in hospital call rotations. And then maybe most importantly, a well-fit clinical productivity incentive, so work RV incentive across specialties. But we had to determine which specialties were a good fit for clinical productivity compensation at this time. So we arrived at 4 evaluation criteria in collaboration with this client: care setting deployment, productivity analysis, a patient panel management assessment, and APP preference, which was really important to them understanding. So understanding how APPs are deployed across outpatient, inpatient, OR, etc., and how typical their mix is relative to their peers helps determine whether they are well positioned to impact their own productivity and how closely they would resemble the participants within benchmarks. In some cases, we even needed to split a specialty. So for example, orthopedic APPs at this client had some that were more focused on a clinic-based setting, whereas others were much more focused on inpatient rounding and providing first assist services. So we had to think about them differently in terms of their productivity potential. We also looked at how the APPs benchmarked on work RVUs against just the national benchmarks, both in terms of their average productivity, but also the range in their productivity. The specialties with tighter ranges and averages within a typical market range implied much more relevancy with the national benchmarks that we were looking at. Those that deviated in either average or range, we had to look into what their scopes of practices were and the range of practices that the APPs had within a given specialty to understand the dynamics of what might be causing that variation and whether they are operational changes that need to occur or if there are just inherent reasons why the productivity differs as it does. Patient panel management also helped us better understand care team models between the APPs and the physicians. So we saw quite a broad spectrum of the APPs that had mixed versus independent or shared panels within their practice, and this certainly influenced how a productivity incentive would impact how they manage patient care. And then finally, we simply asked what they want. Many APPs of this organization were eager for performance-based pay. In fact, we found that it was a detractor to engagement historically, and moving to a a model that really recognized their performance was really important for their work satisfaction. And we got a wide spectrum of responses. Typically within APPs preferring within 5 to 15% of their compensation tied to performance, but ranging really anywhere from 0%, and I think that's like a hospital coverage-based specialty, all the way to 100%, which was a purely clinic-based specialty all the way on the right. So really interesting spectrum of preferences. So next, then we'll look at how these fed into a scorecard that helped us guide our decisions. These 4 indicators we then applied a stoplight scoring system to, and through discussion with the steering committee, which again included several APP leaders, we arrived at initially recommended models, which we had 3 of. One was a salary model, one was a salary plus call compensation, and then finally a productivity model, which was really a hybrid model of a base component, that incorporates some downside risk, and then productivity upside. We had a lot of adjustments along the way, but ultimately half of the specialties and FTEs at this organization we were able to transition to the productivity-based model in the first rollout. And we expect over the years that as we become more sophisticated with understanding the various nuances of their practices and productivity benchmarks, that we'll be able to put more and more on. Next, as this is a webinar on survey results, we do want to dive in a little further into why APP productivity benchmarks can be more challenging to incorporate into comp models than with physicians. And that's on the next slide here. Both physicians and APPs have several variables that impact their productivity, in similar ways. Some is within their influence, such as practice efficiency and their individual effort, and others are outside, such as the type and location of their care setting. But APPs are also impacted by the variance in the scope of practice, which we've talked a lot about so far. Can be determined by state licensure laws, as Maria presented, but also organizational policies and even individual physician preferences, the other practitioners they're working with in the clinic. As such, we actually see a wider variance in APP productivity than physicians, and particularly within primary care and surgical specialties. It is natural to want to center compensation model design around a median percentile, and sometimes that is appropriate still. But for example, it is critical to assess where your APPs really sit on the spectrum of scope of practice relative to a national data set. Considering factors such as which state you're in, how progressive or conservative your organizational policies are, and what the culture is across your provider enterprise. It may make sense to target something less or more than median to recognize the additional headwind or tailwind that the APPs your organization have, respectively. So let's next actually look even deeper into a practice profile example. Here we show 2 practice profiles for neonatal nurse practitioners, and this data is all from the ECG survey. The left CPT category pie chart and the left top CPT codes table represent NNPs in the bottom half of production from our survey, and the 2 on the right represent those in the top half of production in our survey. As you can see, there are drastic differences in productivity and their practice profile. So the below market median average is 577 work RVUs, and the above market median is for almost 1,500 work RVUs. So, somewhere between 2.5 and 3x. You'll also see a difference in the top CPTs that exist within their profiles, and certainly the frequency of those CPTs that are billed. Those more familiar with neonatal care team models can make inferences around these practices and determine which better reflects their own model. You might ask questions like, what's our NICU level, or do we have a hub and spoke NICU network, and where is the NNP practicing? Is the NNP a day or a night coverage? Is the NNP spending a lot of time rounding with residents and providing training? Is there an NNP coverage with MD on-call model, or is this a mixed on-site model? Who handles antenatal consults? Do NNPs and MDs split management of low versus high acuity beds? Who does discharge planning? Who covers deliveries or key programs such as small baby and high-risk infancy, etc. So there's a lot of questions to think about. How might the practice at our hospital be different from those in the national benchmarks, and what's part of the productivity spectrum might it be most reflective of, and how can we use that information to better design our comp models? And so ECG can really help with custom CPT analysis, and also Vault has access to this type of data as well, and it's really powerful in considering your comp design. So let's wrap up this case study on the next slide. So despite all this analysis, APP practices can be so nuanced that we still face challenges throughout implementation of new compensation models. This can likely be expected, and it's important to acknowledge up front with your APPs that adjustments will be required and that leadership is committed to identifying them and acting upon them to get it right. Finally, we'll wrap up with some key change management learnings throughout implementation on our final case study slide here. So we cannot stress enough that if you decide to go down the path of compensation redesign, communication with APPs and those that will operationalize the comp model, for example, payroll, should begin sooner than you might consider. Benefits include building trust, bringing in more ownership of the process, and earlier identification of issues. No small detail is unimportant in payroll. Finally, moving to performance-based models is not only a cultural shift, but may require an operational shift. You'll be amazed at how orgs start rowing in the same direction, and all of a sudden, there are so many ideas on how to improve productivity or other performance-based metrics. But this does take time to implement and adjust to. Applying temporary guardrails to financial impact on individual compensation is very important for communicating that you are in this together and committed to supporting the APPs in the transition. We hope this case study has been helpful as you make considerations for your own organization. And thank you for your attention.
Great. Well, thank you so much, Maria, Sean, and Tanner, for all of the insights today. That really concludes our presentation today. In the last few minutes, I just want to remind folks, if you didn't ask a question, we saw them coming in. We will be following up, as I mentioned, with that FAQ, compiling the questions and our responses to all of the participants. And then also, we just want to make sure you're aware of our extensive library of thought leadership. Don't hesitate to visit us on our website at www.ecgmc.com, and please participate in our 2024 physician and advanced practice provider compensation survey. So we have just opened participation in January of this month for the 2024 survey. We're still collecting data and really would love to get all of you, those who have not participated in the past, in our survey. And then lastly, just quickly on the last slide, just want to announce ECG is really excited. We have recently partnered with MD Ranger, a web-based solution that allows organizations and our clients to help standardize and stream the FMB process. And we'll be adding to our ECG benchmarks the addition of call coverage, medical directorship, and additional available benchmarks around physician contracting arrangements that really expands the data set available to clients beyond the traditional physician compensation, advanced practice provider, faculty compensation, and production benchmarks. So again, just quickly, I would like to thank everyone for attending today. If you have any additional questions or comments, do not hesitate to contact any one of us via email. And as a final reminder, we would greatly appreciate you taking a moment to complete that electronic survey upon exiting today's program. As stated earlier, ECG will make a donation of $5 to Doctors Without Borders for every survey submitted. So thank you everyone for participating today, and have a great day.